And I'll say good morning again for the record. Good morning, everyone. Welcome to another Oregon Health Policy Board educational webinar. Today's webinar is going to be on the Community Information Exchange Overview and Legislative Report. And we have our presenters with us this morning. And before we begin, I just want to remind everyone that today's educational webinar is not an official board business meeting. We will not be discussing anything that leads to a decision. And this is an open meeting for everyone, including board members, staff, and the public. So we welcome you. And if by chance you're not able to stay with us the whole morning, today's educational webinar will be recorded and posted on the board's website for your viewing at a later time. Our presenters have indicated that they welcome questions throughout. So if you have a question or comment, we will take those from board members first, and then we will fit in others as time allows. You can feel free to either raise your virtual Zoom hand, or if you'd like me to read your question, you can always send that in the Zoom chat. And without further ado, I'd like to welcome our presenters, Hope, Carly, and Summer, to our educational webinar. Please begin as you're ready.
Hello, I'm Hope Peskin-Shepherd, she, her pronouns. I'm the lead policy analyst for Community Information Exchange, or CIE, at the Oregon Health Authority. And I'll pass it to Carly to introduce herself.
Good morning, everyone. I'm Carly Hoodronick. I use she, her pronouns. And I am here in a couple of capacities. One as CEO of Project Access Now, which is a community-based organization in the Tri-County area, and also as the chair of the CIE work group that has been meeting over the last year.
And is Summer here? Okay. Well, we can bring the slides up.
I don't see Summer's name, but she could be on the phone or just joining us momentarily.
Okay. Well, once Summer joins, we'll have her introduce herself too. So we are here today to talk about CIE, Community Information Exchange, what it is, how it works in Oregon right now, and also recommendations from a systems-wide perspective on how to support CIE statewide. Next slide, please. So we're going to start today with orienting the policy board at a high level to CIE and the landscape in Oregon. And then we're going to touch on connections between CIE and the OHPB priorities of health equity and the 1115 Medicaid waiver. And then Summer will share examples of how CIE is being used on the ground. And both Summer and Carly will touch on the value CIE brings. And lastly, we'll share learnings from the recently submitted House Bill 4150 Legislative Report on supporting statewide CIE. Oh, good. Hi, I see Summer has joined us. So we will have Summer introduce herself in a few minutes. Thank you. So some of you may have heard us speak about CIE before, but we wanted to give a refresher. Next slide, please. So what is CIE? CIE is a network of collaborative partners using a multi-directional technology platform to connect people to the services and supports they need. So to explain that a bit more, moving from left to right in the graphic, a person, oh, thank you. A person seeking help is referred to services they need through the CIE platform, typically working with a helper or a service provider, although depending on the tool, there are different ways for a person to request services or self-refer. The CIE platform documents information about their needs, as well as their consent to share their information. The organization helping them can search for appropriate resources in the CIE and send a referral to another organization. This receiving organization indicates if they were able to provide the services or not. So the referring organization, that original organization, sees what happened with the referral, a process known as closing the loop. And partners on this may include human and social services, healthcare, and other types of organizations. And the technology functions must include closed loop referrals, a shared resource directory, and informed consent. Next slide, please. What this looks like in Oregon right now is that there are CIE efforts developing across the state, largely sponsored by Medicaid Coordinated Care Organizations, or CCOs, health systems, and health plans. Community partners, including community-based organizations, or CBOs, clinics, local public health departments, and others participate in these efforts throughout the state. There are two main CIE efforts in Oregon, shown by the maps here: Connect Oregon, which is powered by Unite Us, and Find Help, formerly known as Aunt Bertha, and also locally as Healthy Klamath Connect. And so these maps show the availability of sponsored CIE efforts in Oregon as of this month, meaning areas where there is a CCO health system or health plan investing and supporting the spread of CIE. This is not to show the level of adoption by providers or CBOs. And also, to be clear, OHA is not using CIE anywhere at this time. And the Oregon Department of Human Services is adopting it only for their emergency management response at this time. However, the landscape is a bit complex. For example, since Idaho uses Find Help, those in Malheur County have interest in using Find Help as well. So Eastern Oregon CCO is looking into ways to support that community, given that partner organizations might be using Find Help. Next slide, please. There are a few ways we see CIE could be a tool to support various OHA and OHPB priorities. And one of those is the recently approved 1115 Medicaid waiver, specifically the health-related social needs services for transitions populations. Oregon Health Plan or OHP members often lose access to care when going through major transitions. And under the waiver, we will close gaps in coverage and care and provide supports for health-related social needs. Sharing health and social needs information across organizations is a key support for this work, and technology can help ensure that an individual's information is in the right place at the right time, and that information follows an individual through their life transitions. And CIE can be one of these technology tools to help stabilize transitions and minimize disruptions to care. Next slide, please. And I'm going to pass it to Carly for this one.
We're going to bounce back and forth just a little bit. Thanks, Hope. So we know the Health Policy Board and OHA have a robust definition and priority to work towards dismantling inequities in our state by 2030. And I was actually really honored to have an opportunity to participate in the development of the definition of health equity for the state several years ago. So I thought I would just take a minute to pull us back out and frame CIE in the context of that goal. So there are three levels at which health equity is improved or comes in closer alignment with achievement through a CIE. The first is that a CIE can help service providers of all kinds, not just physical, mental, oral health, but social service as well, be better connected and more aware of the ways to support someone beyond the scope of their individual practice or organization or agency. Second, and I think what we think about the most when we consider CIE is, the fact that people need their general needs met to achieve equity. And those are everyday needs, food, employment, housing, all of the health-related social needs that we understand impact health and really drive health. So CIE as a tool and a space to share this information can support navigating people to available resources. And in an ideal state, it really enables a more person-centered approach by ensuring that folks answer potentially sensitive questions about what they're experiencing, what their missing in their lives, what they might be eligible for, only one time as they enter a CIE, rather than multiple times as they're trying to navigate access to a plethora of resources. And then lastly, kind of that third box on the bottom right, at a population level, the data that highlights when we run out of partners to refer to or have gaps in resources is really imperative at informing the policy discussion at a higher level to change how we allocate resources over time. And now, if you go to the next slide, I'm going to turn it to Summer.
Thanks, Carly. I hope you guys can hear me. I'm in the office and I apologize for being late. I'm having tech difficulties at work, so fun stuff. But I'm glad I'm here to introduce myself. Summer Sweet. I'm the Triage and Data Integration Manager at the Population Health Department at CARE Oregon. And I'm going to highlight some use cases of our use of the Community Information Exchange, specifically with Unitas. Please move the slide to the next. All right, so early in 2022, we actually established a relationship and provided a grant for Portland Fire and Rescue. And it was key that they had a quick way to refer to us. And so I just am highlighting at the very first kind of the process of what Portland Fire and Rescue did to use the CIE. So first they have a 911 call and they come in and they assess and treat the individual in the community. They identify that there's actually some social needs or care coordination needs. And when they do that, they actually obtain consent from the member direct on the actual application. They can sign it directly or they can attest for that individual. Right, using the Unitas application will then send a referral to us in which we would receive that referral and they would get a direct response once we actually accepted the referral. So that's that closed loop. And we can receive a referral for any reason. Unfortunately, with care coordination, it shows that it's physical health, but they are the majority of the referrals we receive from Portland Fire and Rescue is really for behavioral health. And I want to show the next slide to give you a little bit of an idea of what that data looks like. I just highlighted 2022. So like what Carly was speaking to is the data is key, right? Being able to kind of see in a big high level overview of what is happening, what kind of referrals are coming into our teams. And then when that consent is provided, when we receive that referral, when we receive that referral, we actually do another assessment internally with the individual to further identify their needs. And we can quickly just go ahead and refer within the application to other services that are needed in the community, like food boxes or shelter or individuals and family support, which is a big actual need within our community network. But this right here is just really highlighting the amount of cases that we receive directly from Portland Fire and Rescue. So, and then I also wanted to highlight, because we actually serve about 7 different counties. And so we have a Jackson Care Connect, which is our county down in Southern Oregon. And so I wanted to highlight their work. If you want to go to the next, apologies. Yeah, so our mobile integrated health. So you can see that we leverage a lot of our community partners that are having direct patient contact in the community. And with Mercy Flights, they actively go seek our individuals either in the hospital while they're admitted to the hospital, and they'll do a needs assessment with the individual. And then they will also obtain consent and refer to us if there is a care coordination or further needs for long-term kind of case management. A lot of these community-based paramedics techs that are on the scene or RNs that are on the scene don't do long-term case management. And so a lot of times they need somebody to hand off to and be able to see that that handoff actually occurred. So that's the great piece about using and leveraging the CIE in order to get that closed loop. So they get to see, and then if for any reason the individual contacts them, they can add notes to it and we get alerted to that. Same thing as we're providing any updates on the individual's case, they will also see that in case of a member ends up readmitting to the hospital. In a lot of the referrals, there's like direct pathways that Mercy Flights uses it to engage them into primary care. So if you look at the next slide, you'll kind of see that data. And I, again, just only highlighted 2022 just to make it cleaner, but you'll see that the majority of the referrals are for physical health. However, they did engage them in some behavioral health providers as well. And a lot of the referrals are going mostly because they have a really direct, good relationship and connection to the providers, especially La Clinica, that the majority of those referrals were going direct to La Clinica, which is a primary care in the area. I don't have anything else unless anybody has any questions for me or want me to ask, or you want to ask me anything. I'm willing to kind of divulge more.
Thanks for that, Summer. Yeah, if anyone on today's educational webinar would like to ask a question, we usually prioritize our members, but we have
Okay, yeah,
on today. So anyone's welcome to raise their hand or send me a chat and I can read that question out loud. I do see we have a hand up from one of our vice chair and member, Kristen Isaacson. Go ahead, Kristen, and good morning.
Hi, good morning. This is really exciting to see this to see this be. Heard about this for years, and so it's super exciting to see this. I was curious, very interesting to see how these referrals are being made and the directionality of them. I was curious about kind of referrals from maybe the opposite, like from a primary care setting. Oh.
Yeah, so we've been getting some referrals from our primary care here in the Portland metro area, and it's essentially the same. It's really a simple workflow. It's just when they identify a need, they go in, they identify the individual. If the individual has already provided consent doesn't need to be obtained again. And then they will just submit the referral, find the resources and submit the referral to us. So some provider offices will directly refer to us for care coordination, but they too can also directly refer to community-based organizations at the same time. So that's kind of the beauty of it, is you can do a bulk referral to multiple different resources. And it's a little bit more simplified than if I were to pick up the phone and call like all the different ones and go online and try to find all of the different resources available. The other beauty that is nice, like let's say an individual is not sure about providing consent yet, they don't know enough information, you can always send resources direct from the application if they're willing to give you either an email or a phone number that allows text. And so you can still provide those community-based organizations. You're just going to lose that activity of a closed loop referral. So that's the only piece that I like to highlight. It's like you're not going to get that data to make sure that they actually connected to the service. And that's really what we want and hope to see, is that they're actually receiving the services that they're getting referred to.
That's great. And just sorry to hog this. Sorry, you should move me along. There's other questions, but do you have any, and this might be coming later, do you have any information about kind of adoption within care settings and how
Yeah, I
Yeah.
mean, that's a good question. I'm not the best individual to answer the actual full adoption. I know our entire care coordination team, at least in Care Oregon, has adopted and has logged on and learned about the system and have used it. Now, the network saturation is still onboarding and building. Every day I kind of see a new provider in there. So that's great, you know, and I love the functionality of when providers, so let's say us as a provider, because we accept referrals on the application, if we feel like we're at capacity or we don't have availability to accept it, I can go in there and change that in immediate time, and then I can go in and update it. And so that's what's nice. If I end up seeing that, oh, I have a new service available and I can add a new service within the tool for accepting referrals, I can go in and do that at any time. So that functionality of configuring what I'm willing to accept or what I can accept is there. But as far as the network, we do have a whole team that's really supporting that work, and they would be probably better versed in providing all of the adoption across the landscape of the state and our service areas specifically. I can ask though.
Kirsten, any more follow-ups? Okay, it looks like you put your video down. Yeah, we had a couple other questions come in, Summer, while you were answering Kristen's question. So the first one kind of, maybe you spoke to it, but if there's any additional like examples of the specific services, because we did get a question on if you could share more about how CIE is used to refer to social supports rather than physical health. And I know that you spoke on that a little bit, but if there's any more like detailed examples or walkthroughs of how you could speak to that, or if you think that you've shared sufficiently. We had another question that was curious to hear about how you monitor referrals on members.
Yeah, so first the services for social services. So food boxes are a great resource on there. We have a benefit that is available to our members to receive meals delivered, and we're looking at leveraging the Unitas application to submit those referrals for more transparency. So that is coming. We're really excited about that. We're hoping to have that live in the next couple months. And then as far as like to manage all of your referrals and accepted referrals that you have, there's a dashboard when you log into the application, and it allows you to either look at your organization level. So somebody like me, I'm accepting all the referrals across our entire team. So I need to have that like periscope view of everything that's coming in, and I can go in and I can process those. They have different statuses of where they're at. So they're all kind of tracked on an actual dashboard. We too receive weekly files of the background data in the system. So we also have built our own dashboards internally just to capture that information to better prioritize what kind of resources we need to provide for our individual members. And then also looking at like where are our needs at, like where are members actually getting referrals that aren't getting accepted? You know, is it because we don't have CBOs available? So maybe we need to start funding sources in certain different areas, such as like income support or utilities. We're seeing that a lot of utilities are getting denied. Maybe we need to go have a conversation and see why that's happening and see about opening up those available resources.
That's great. That's awesome that you have such a view and access to those individual referrals to follow up to see what may need to be further supported to ensure those services are provided. We had another question come in. The person is asking, they're assuming the examples focus on Medicaid patients in CCOs, but eventually the CIE proposed will be across the population. So that would include commercial and Medicare patients as well. So I think they're kind of asking to clarify the population.
Yeah, the system itself is insurance agnostic. I would like to call that out. Like, it's really not about the insurance within, like, leveraging this tool has nothing to do with the insurance. I'm just coming and showing up for like a CO Advantage and CCO plan. And that these are our specific use cases of what we're using. However, any CBO can accept referrals from providers based on any kind of criteria that they set. So providers, when you open yourself up to receiving a referral, you put in those parameters of what your criteria is. And some may be insurance specific, like, hey, you have to have Medicaid, or you need to meet the FPL, or there's different kind of criteria you can set. But I would say that the CIE, at least Unitas in itself, is not specific to insurance. It's just this one use case. And so an individual that is seeing their primary care, needing a food box, and may not be on Medicaid or may not have any insurance, they can still have a referral be placed to receive those services.
Great, thank you so much. You did such an
Mhm.
excellent job explaining those questions. I have
Good.
nothing else in the chat, and I don't see any hands up. I believe we can proceed.
All right. Thank you.
Great. I think I have the next section. So if you could move to the next slide. So Summer did a great job at kind of hearing what this looks like on the ground or in use case scenario. I'm going to share a little bit of background on the state level group that just submitted a report to the legislature highlighting sort of what's required at the policy level to make this work sustainable and farther reaching than within potentially just the Medicaid space. The next slide. So House Bill 4150, which passed in the 2022 short session last year, directed the Health Information Technology Oversight Council, or HITAC, to convene one or more groups to explore strategies that would accelerate CIE and provide recommendations back to the legislature on how to continue to accelerate CIE. HITAC late last year chartered a CIE work group with diverse membership. I'll share a little bit about what membership looked like across Oregon's landscape of community healthcare and social service providers. And then the CIE work group met monthly from March to November of last year and developed legislative recommendations, which were then brought to HITAC for finalization and review. Simultaneously, OHA engaged a health equity consultant who conducted interviews and a survey with 99 community-based organizations on their experience, thoughts, and concerns with CIE. And then those three areas, the CIE work group, the CBO survey and interviews, and then HITAC input, were all brought together into the draft final House Bill 4150 legislative report, which was submitted 2 weeks ago to the legislature. And there's a link to that at the bottom of the screen. Recommendations will be used to inform, hopefully inform future legislation, potentially this session, and will definitely be used to inform HITAC's strategic plan for the state as OHA supports kind of building that work out a little bit more. Next slide. So the House Bill 4150 outlined broad representation for the work group, including representation from healthcare, social service, CBO, behavioral health, oral health, and organizations that advocate for or serve communities facing inequities. I think a couple of you have raised good questions already about how are social service or CBOs involved in this. That sort of makes the distinction between what we would classically think of as an HIE, health information exchange, passing information between health entities. To kind of breach that wall means we're going more into the community space. So it was really important that there was representation on this work group from those social service providers. Members had to apply to the work group through an application process, and ultimately the work group ended up being 18 members. 2 of those members, myself and Dr. Dorr, also served on HITAC or serve on HITAC, and so we were liaisons to the CIE work group and back to HITAC. And the bubbles on this slide show kind of work group members' organizational and professional experience or identities. Members fulfilled more than one area, which means you'll see more than 18 numbers here. But want to lift up 40% of work group members were associated with a CBO, and there was one representative of a AAA. Beyond that, across the group, members highlighted work or volunteer experience with populations that face inequities, including work or personal experience, inclusive of incarcerated youth, being a person of color, LGBTQIA, having personally accessed public services historically, experience working with houseless, rural, and/or indigenous populations. So there was a big swath of experience, lived, personal, and volunteer, that informed this work group's recommendations. Next slide. So in April of last year, one of the first meetings we had, the CIE work group members endorsed a vision and a CIE definition. The vision of the work group is here on the screen. I'll lift up specifically that all people have access to a community information exchange, so it's not relegated to any particular organization or entity, and that information exchange creates seamless, trusted, person-centered connections and coordination, and supports community capacity, eliminating silos to achieve health equity. And much like all visioning statements, this took a lot of input, a lot of thoughts, and I'm really grateful to the OHA team for helping distill what the work group members came up with. Next slide. So from the interviews conducted by the consultant, and you can read that full, it's a very long, in-depth report where you can hear specifically from CBOs. But participants highlighted a number of benefits of being able to use a CIE, and I wanted to share just one here. This is one respondent's personal perspective, paraphrased a bit. We're always underfunded, we're always understaffed, and a CIE would cut down on hours and hours of time that we would be on the phone. All of these things have made it a lot easier for us to operate, made it to where we can spend more time with our feet on the ground. And I think that was a general sentiment in terms of looking at kind of the benefits of a CIE. If you go to the next slide, before I turn it over to Hope, you know, I mentioned I wear a related hat as the leader of a nonprofit CBO here in the Portland metro area. And my organization sits really squarely between health systems and community partners. So we would have a lot to gain from a highly operational, neutral, and well-functioning CIE. I can speak, you know, from experience, recognizing our clients would benefit by having services in their preferred language, and an ability to refer out into other partners that would help support their specific cultural needs. Our clients would benefit by having to tell their story fewer times when they interact with us, and then the food bank, and then community clinics, and then IRCO, again, reducing re-traumatization and really allowing people to tell their story once and then get the wealth of services that they deserve. And as a CBO specifically, we would benefit by simplifying how we connect people with social services, not having a bunch of different tools to make those referrals or needing to pick up the phone, as one of my peers mentioned. And then improving care coordination across a variety of health and social service partners by being able to share those referrals and see where the closed loop occurs. So just wanted to share, you know, I think I wear two hats, and I think it is really important to understand from the CBO perspective how impactful a CIE can be. Hope, I'll turn it back to you.
Thank you. Next slide, please. So I'm going to turn back to the legislative report under House Bill 4150. And this brought together the work of the CIE work group, community perspectives via CBO input, and comment from the Health Information Technology Oversight Council, or HITAC. And so, as Carly was saying earlier, this report and these groups really looked across the CIE ecosystem, so to speak, and thought about what is needed long-term to make this work across the state. And these three groups aligned on several overarching priorities to support, accelerate, and improve statewide CIE and to ensure CIE efforts reach the ultimate goal of supporting health equity. And so the first priority is that CIE requires investment in systems change, which will take time, as well as building trust and relationships to connect across silos. And the recommendations in the report highlight that building relationships across CBOs, OHA and ODHS, and additional CIE partners such as behavioral health, local public health, county social services, and others, as well as the individuals being served, will be key to successful statewide CIE. And we have a quote here from one of the CBO interviewees that also emphasizes that point. And it says, no matter how complicated or sophisticated or fancy that system is, the platform is, it's always going to depend on relationships. And then the next priority recommendation is that support for CBOs is paramount. So CBOs are a priority partner for the success of CIE and must have support to participate, as well as be leaders in decision making. The third priority is that CIE should promote equity and be accessible and person-centered. CIE could promote equity by getting more services to more people most impacted by health inequities. It's also important to prioritize culturally and linguistically specific organizations to ensure CIE efforts reach this goal of supporting health equity. And CIE needs to adequately address literacy, language, and digital access needs. It's also important to note that the CIE workgroup sees a role for OHA and ODHS in ensuring CIE efforts do support equity and that CIE is accessible. Next is that inclusive and neutral statewide governance for decision-making is needed and must be responsive to CBO and community needs. And finally, privacy and security of data must be prioritized, and transparency and accountability are also essential to building trust. Next slide, please. So beyond the CIE work group, another aspect of developing this report were those interviews and a survey with 99 CBOs. And there was a significant amount of overlap between the work group, CIE work group's recommendations to support CBOs and the priorities, barriers, and recommendations from CBOs in the community engagement report. And I'd like to highlight some of those needs here. So the need to support CBOs in adopting and using CIE by supporting staff capacity, offering funding, technical assistance, and training continued to come up. And here, this first quote from one of the CBO interviewees underscores this need for staff capacity and funding, saying, if you wanted to really open the doors and really have it be a successful system, we would need a much more increased capacity, which would be staff costs and all the other things associated with that, including infrastructure money. CBOs and the recommendations also noted the importance of privacy and security and training on this topic. Also, the need to communicate clearly about privacy with organizations and clients. Something that continued to be emphasized throughout the report is the importance of centering communities and populations that experience inequities in decision-making. And one CBO survey respondent shared, I think the CIE needs to be more than just culturally and linguistically responsive, but it also needs to be responsive to each community it is working within. That means being a part of the community, listening to the community. We have not seen that. And lastly, CBOs noted that a referral coordination center, a place that could centralize and help direct referrals to the appropriate organization, would be helpful. Next slide, please. And lastly, the CIE work group's recommendations themselves. So over the course of 2022, the work group looked across many different areas in CIE efforts or different parts of the CIE puzzle and developed comprehensive recommendations on what is needed to support CIE statewide. So again, the CIE work group recommends that legislation support CBO participation in CIE. This should include ongoing sustainable funding and grants, technical assistance, coordination and convening, and education. So this area came up across all of the groups that provided input to the report repeatedly. Next is additional partners also need support to participate in CIE. And these additional partners, again, could include behavioral, oral, and physical health organizations, local public health or county social services, safety net clinics, and others. And this is to emphasize that these other partners are also important to statewide CIE. That this is a collaborative network that involves all different types of partners to connect across silos. Next is that OHA and ODHS should have certain recommended roles in statewide CIE efforts. And this should include OHA and ODHS participation in CIE and program use where appropriate, supporting and participating in neutral statewide governance, leveraging policy and contractual levers that can support CIE, and supporting CBOs and additional partners in their participation. The next recommendation is that the CIE work group recommends legislation support a statewide CIE data program. And so this would support data transparency and leverage data to identify gaps, strengths, and opportunities for improvement in Oregon's social care system and in CIE itself. And then the next area is that the CIE work group recommends several privacy and security principles, as well as considerations that should be accounted for when considering statewide CIE. And the principles center a number of things, including community and individual decision-making around use of their information, adherence to applicable privacy and security laws and national standards, and also transparency around how information is handled. And the last recommendation is that the CIE work group recommends statewide governance, and that this should be inclusive and neutral, led by a neutral third party or public-private partnership, and should be representative of the individuals, communities, and organizations participating in and impacted by CIE efforts. And additional questions remained on this area around what would be governed, what power governance would have, and the potential impact on current CIE efforts. Next slide, please. So what comes next for CIE after this report? So we anticipate this report will inform legislation related to CIE this session. There are priorities in the recently approved 1115 Medicaid waiver that could be supported by CIE. And this will also feed into high-tech strategic planning work. And additionally, those in the landscape continue to move work with CIE forward with new use cases and opportunities. And I also wanted to pause for a second and see if John Santa, our high-tech liaison, wanted to add anything.
Yeah, thanks, Hope. I'll leave my video off because I think I have some bandwidth issues. Well, boy, I have learned so much from watching this process and learning from it. You know, you kind of begin with, well, CIE is a tool. But as you listen to this presentation, it's so much more than that. I mean, most of the conversation's actually been about relationships. And I think oftentimes we think just the presence of a tool will solve problems when, when actually it creates opportunities to solve problems if we can figure out all the relationships that need to occur and occur productively. This whole process, I think, is interesting because my colleagues on the board, here's a process designed to reduce the risk that down the road we'll look at this and say, oh my, this was inequitable. One group of people is benefiting much more than another. So for example, it's statewide. And the term neutral governance, isn't that an interesting term? And Hope's comments a few minutes ago describing the governance process as a public-private effort. So there really has been a lot of thoughtful input here and conversations about, you know, how to do this together. The CBOs have also been, thanks to folks like Carly, very involved in this. When I read a study involving the interviews, 90-some interviews of CBOs, I learned so much about their situation. And finally, at the last session of High Talk, when there was a presentation around the waiver, a major issue was addressed, at least for me, which where's the funding for this going to come from? And it's going to come from potentially the waiver that the CBOs may be able to be supported through the funds that come through this in a waiver. You know, as I listened, I couldn't help think a lot of people might say, well, the market should take care of this. Well, the market's not going to take care of this, and it's not going to take care of it equitably. We know that. And so I'm just thrilled to see that such thoughtfulness has been put into this work. I also couldn't help think that later today, I'll be trying to help two good friends who are both pretty demented. They're Medicare folks, and oh my, do they ever need this? Do their doctors ever need this? They are just struggling, and my guess is they'll end up in the emergency room. You know, despite enormous individual resources, they'll end up in the emergency room in crisis, rather than this being done in a thoughtful, coordinated way. So really great work, a really good example of the way to do things going forward from an equity point of view and a funding point of view. And I'm just thrilled to have had a courtside seat to watch this unfold. Thank you.
Thank you so much. Next slide, please. I think we're just on questions now.
Great. Thank you so much, Hope, Carly, and Summer. You did an excellent job today and very informative, interesting, great work. So we appreciate all that you have done, and thank you for taking the time this morning to share. With that, we have about 10-12 minutes. If anyone on today's educational webinar has a question or comment that they would like to share with the presenters in the group, you're certainly welcome to raise your hand, unmute yourself, or send a chat. And then while we wait to see if anyone has any questions or comments, do any of the presenters do any kind of final thoughts or comments you want to share? And I guess you could be thinking of that if there is anything while we have a question. We have a hand up from Melina Moran, one of our members. So go ahead, Melina.
Hi, good morning. Wonderful presentation. And I love this work. As I used to work in primary care, and coordinating services for people is quite daunting and time consuming. So thank you. I love this. One question I do have is when the patient or client signs the authorization, is that a release of information to be shared, or is it HIPAA compliant? How much information can be shared between organizations and on that dashboard?
I assume that's for me. Yes, it is HIPAA compliant, and if it does follow 42 CFR. So if for any reason there are referrals that are meant to be secure, only the recipient receiving that referral would see that. It wouldn't be shared amongst anybody accessing the tool. It allows for the use of the tool to provide referral information, so requesting services. And most people put the majority of their documentation in their own systems, not within the Unitas application. At least that's what I can speak to. So it is essentially consent is obtained at that time to use the tool to submit a referral for those services. And then the majority of people's documentation usually lives in their own application, and a member could always request those records and then also request to rescind their consent as well.
Thank you. And then also just another question is, I was wondering, does a member, when you speak of members, is that the CBO or is that actually the patient/client?
I'm speaking patient client.
Okay, so so they have to have access to computer, phone, Wi-Fi. Okay.
It all depends. You can request, I could obtain consent for you by reviewing and reading off exactly like a user attestation. And so I'd read to you exactly how we would use the application, and you could provide a verbal consent and I would sign. The other ways is I could text it to you. I could print it and mail it, and you can sign it and mail it back. Nothing would be shared until that consent is provided. So we could queue up a referral, and if you decided, oh, I want to review the entirety of the form, I can mail that form to you, and that referral will be queued up. But until I receive that form and update it and load it into the system, will the actual referral be placed?
Thank you.
Mm-hmm.
Thanks for that, Summer. And that's great that there's so many different opportunities for someone to provide consent. Makes it more accessible to more patients. I'm not seeing any other hands up at the moment, and I'm going to check my chat. It looks like I don't see anything in chat, but Melina did send me a chat question earlier that I was trying to get to the presenters, and Melina had asked, and this is in regards to the work group. And Melina Moran, one of our board members, asked how many people of color are in the work group and what kind of language access is available for the CIE. Carly did send a response, and she thought it was about 15% people of color identifying in the work group. But I think that we were all wanted to see if Hope you could confirm that, and if there was any kind of like additional information that maybe there is to offer about the members of the work group.
I would have to go back and confirm that, but I think earlier when Carly was sharing the various lived and work experiences that people had shared as well, that's what we're able to share. So people had shared that they have, experience with incarcerated youth, Latinx populations, working with Indigenous and Native populations, houseless populations, rural populations. So, with us 16 and then Carly and David Dorr member work group, we really tried to find representation both across the landscape of all the types of partners that could be involved in this, which, continues to grow and spans across physical health, oral health, behavioral health, data research, people using CIE and people not using CIE, and of course, people who work at community-based organizations or work on health equity and social determinants of health. But that's the information that we're able to share.
Thanks, Hope, and thanks to you and your partners there for doing such, such a great job at exploring, people's lived experiences and cross-cultural experiences beyond just demographics, but really making sure that that work group is representative. So thank you for sharing, and thank you again for that work. I guess this is going to be like my final call. If there's any final questions, comments, feel free to let us know. If not, always feel free to contact me or any of our presenters if you have any additional follow-up questions for today. Today's
Tara?
slides, as well as the links I shared, are available on the board's website, and our recording will be posted probably within 48 hours. I feel like I heard a noise.
Yeah, Tara, this is John.
Okay.
Could I just ask that the OHPB be kept informed of the progress of this in the legislature of this bill?
Yes, we certainly can. I will ask, Hope and her team if anything monumental is moving, let us know. And I can also flag this for the government relations team, as they will be routinely visiting the board over the next several months during the session to provide updates. So certainly good call out. Thank you for that, John. And then I think we can go ahead and tell everyone have a great day, and thanks again for our presenters and all this hard work. We really appreciate it.
Thank you for having us.
Of course. All right. Have a great day. Take care. Bye.